I can see that people are joining. So welcome to people are joining. This is the HLA and Paediatric Blast Injury Partnership webinar on children living in conflict. Welcome, everybody. We will have Arabic interpretation. We will have Arabic interpretation today, so please go to the interpretation button at the bottom of your screen. You might need to click on the 3 dots to access that, and then choose the Arabic channel if you need it. And we are recording today as well. If you have any questions as we go through, please post them in the Q&A box. And we also have the chat function enabled as well. So feel free to introduce yourselves in the chat if you would like. We will get started in 4 minutes. So just getting people to join. I can see we have 60 participants online right now, so welcome to you all. As I mentioned before, we have Arabic interpretation available, so please feel free to go to the bottom of your screen and access the Arabic channel if you'd like to use that. This session is being recorded today. You are able to post questions or comments on the chat. You're welcome to introduce yourselves or post questions in the Q&A box.
Can you hear me, by the way?
Yes, I can. Hans, welcome. We've not quite started yet.
Okay.
People are just coming online, and then we'll go to, I'll just introduce and hand over to Chris to start.
Sorry for being such a pain with the slides.
No, that's perfectly all right,
But
Hans.
I tested it. I think I can, it will pass.
Amazing. Yeah, and it looks like a fantastic talk. We're very happy to have you today. And if you don't mind, if you stay off camera, yeah, and then just come on camera when you're gonna speak. Al-Mathana, also feel free to come off camera until you're ready to speak. But everyone's welcome to post in the chat. Welcome to Nermeen Abdel Nasser from Cairo. Thanks for posting an introduction, and really happy to have you here. The Arabic interpretation channel is available. It's accessible at the bottom of your screen. You might need to click on the 3 dots to find the interpretation option, and then you just choose the channel that you want. And we will have place for questions and question and answer at the end. But do feel free to post questions in the Q&A box during the talks if you would like to. And welcome to Noor from Gaziantep in Turkey as well. So I can see that, and welcome Sharif. I can see that we have 85 participants online right now. We'll be starting in 1 minute. While you're waiting, please feel free to introduce yourselves in the chat. This is the HLA webinar hosted in partnership with the Paediatric Blast Injury Partnership. On children living in conflict. We have a range of experts from different disciplines. If you require Arabic language interpretation, please click on the 3 dots at the bottom of your screen and choose the interpretation option and click on the Arabic channel option. And this recording is being recorded in both languages. Welcome, Ala, nice to see you. And Dawn, Tembasani, really good to see you. So welcome everybody. It's really good to see such a large turnout for this webinar. I can see we have 90 people online already, and people still joining. So welcome to this webinar, which is entitled Children Living in Conflict, hosted by the Humanitarian Leadership Academy. We are a capacity strengthening organisation, a department of Save the Children UK, and we have a large presence in Middle East region, so we're really happy to see so many participants from there today. We're hosting this in collaboration with the Paediatric Blast Injury Partnership. We're very proud to be partnering with them to bring you this session. And just a couple of housekeeping. So we have a range of speakers. This session will be chaired by Dr. Chris Hook from the Paediatric Blast Injury Partnership. We will have Arabic language interpretation available. So if you haven't already and you need Arabic language, go to the 3 dots at the bottom of your screen, click on the interpretation option and click on the Arabic channel. There will be an opportunity for questions and discussion at the end, but there's a Q&A box, so please pop your questions in the Q&A box, not in the comments. But please do feel free to make use of the chat for introducing yourself and interacting with other participants. And this session is being recorded and in both languages. And with that, I'd like to hand over to Dr. Chris Hook to start the session. Many thanks.
No, thank you very much, and thanks everybody for joining us online today. We have an incredible lineup of speakers, of which I am not one. So I will just say thanks for attending. Please stay online, and that this is a really important topic. I have had the pleasure of working with many of the speakers on various projects associated with the care of children living in conflict, and you will hear a lot more about all of those projects throughout the next 2 hours. Yes, it's a really important thing. So stay online. If you have questions, please pop them in the chat and in the Q&A, and we'll get to them at the end. But I'll start by introducing Dr. Paul Reavley from the Paediatric Blast Injury Partnership, who will say a little bit about what that is and what they've achieved. So over to you, Paul.
Sorry, thanks, Chris. I'm just checking that we've got audio and you can see the slides. I'm not sure if anyone can reply. Great, thanks, Chris.
Yes, we can. Yeah.
Thanks for inviting me to talk. And I've only got just a couple of minutes to introduce the Paediatric Blast Injury Partnership and the work that we've done with some great colleagues in the last few years. But just to give you the background. This is Eglantine Jebb. She founded Save the Children over 100 years ago in the aftermath of European conflict in the First World War. And she did that to raise money to feed children in post-war Germany. And one of her famous phrases and variations of was that every war is a war against the child. And this was relevant then for different reasons, but remains relevant now for many reasons, some of them worse. And as we know, there is a huge burden, I think Hannah will talk about this more subsequently, of children and the outcomes of conflict on them globally, with many millions, hundreds of millions living in conflict zones where they're at risk of conflict type injury. And that burden has got worse over the last years and not better. So in 2017-18, we were asked by Syrian clinicians to help basically, and we brought together a group of people, Save the Children, Imperial College, and some clinicians, independent clinicians, to look at how we could help clinicians dealing with children, or help with this issue of children in conflict. And we looked at various areas: research, clinical support, and advocacy. And since then, we have been working on clinical resources. We have established the research facility at Imperial College into blast injury in children, and Save the Children, amongst other partners, have continued with the advocacy work in this area. Now, the partners involved are Save the Children, Imperial, the HLA. We have partners in Qatar. We have many clinicians around the country and the world who've contributed to this, and other NGOs who've helped us achieve various things, which we'll come on to. So what is the issue with children that we are trying to address? Well, frankly, if you're an injured child in the world, particularly in conflict injury, the likelihood of you being met by a pediatric trauma clinician is low. And we present ourselves with many barriers to success. So dealing with children, we're unfamiliar with them. They're psychologically different. We find it psychologically different. We have barriers in the way of success. It's emotional. There are communication challenges because they're a child. We find the procedures that we do slightly harder unless you're used to them, if you're not a pediatric clinician. And sometimes we need special equipment. But if you were a Ukrainian family doctor 3 years ago or 2 and a bit years ago, you would wake up suddenly one day not to be a family doctor, but someone who would be having to deal with injured children. And that's happened all over the globe. And we want to try and help people overcome this. Because quite frankly, when we are faced with injured children, we get scared about how we deal with them. And not all of that is valid. So we as a group have developed various resources to try and help clinicians and try and help people deal with children at various points of their injury pathway. The first piece of work we did was following that meeting with Syrian clinicians. And I see we've got colleagues from Gaziantep. We went to Gaziantep and met Syrian clinicians there to talk about what kind of manual and what kind of resource they would need. And we produced the Paediatric Blast Injury Field Manual, which was released a year or so later. That essentially is a manual that will help you with the injured child, not just for blast injury, despite its title, but any kind of injury, from the point of injury through the care of the chain of care, through theatre, through paediatric intensive care, anaesthesia, ward care. And it contains not just the physical aspect of care, but also the psychosocial aspect, which is so critical. Now, the other resources that we've developed subsequently, and that manual is now available in several languages, and I'll direct you to a link at the end of this brief talk. On the back of the manual, we've also developed some training courses with the partnership, and they include bystander courses, which we've delivered in Cairo to try and assist with the efforts in Gaza, which, as you can imagine, was terrifically difficult. We have developed a UK-based trauma course, on which we're able to build other courses. And we've got a kind of overseas, if you like, course for medical response, which has been delivered in various places, including Ethiopia. And I think, hopefully, we're about to deliver it in West Bank. The other resources we have, and I'm not sure if I'm including that with one of my things, is an emergency pain manual, which we developed last year. And this, again, just guides the clinician on how to deal with pain in children. And it addresses not just the pharmacological routes, but the critical psychosocial and physical ways of dealing with pain in all ages of injured children. And then down the bottom there, relevant to recent things, we have a Stop the Bleed card and animated videos, which are very kindly and amazingly done by the HLA and Reavley's team, on how we deal with the immediate injury in a child. And then this is one about how to apply a tourniquet, but there's the general approach to the injured child. And this is all based on the manual. And they're available online, and all of these resources are free. So the partnership exists to continue doing this work, clinical resource, advocacy and research. And we are always very interested to hear from colleagues about how they might want to contribute, or how we may be able to help them with anything that they need. And like I say, all of these resources are free to use, free to take, free to adapt, and free to modify and insert for your own purposes wherever you are working. The link to these is to a new website, which has just been started, and everything, I think, perhaps not the videos, but you can contact us and we get them. They're on YouTube, basically. But the link to all of these resources where you can download them for free is through that QR code, as well as some contact details for the partnership. If anyone wants to get in touch about how they can help or how we can help them, we'd be delighted to hear from you. And I think I had 5 minutes, and I think I'm done, Chris. So thank you very much, everyone, for signing on. It's wonderful to see so many people from so many different parts of the globe with a common interest.
Thank you very much, Paul. A fabulous project that's really taking off. And please do get in touch. We'll post the website again in the chat a bit later on as well, and give you the opportunity to sign up for involvement and possible future courses. So moving on, thank you, Paul. We're going to now hear from Dr. Hannah Wild, who will introduce herself and take things forward. Thanks very much, Hannah.
Thank you. I'm outdoors to get a connection. Chris, are the acoustics okay? Is the wind a problem?
No, you sound perfectly fine at the moment, Hannah.
All right. My name's Hannah. I'm a surgical resident focused on improving civilian casualty care in modern conflict, focusing on low resource settings. You can go on to the next slide. Thank you. There's almost an algorithm for the way that we hear about atrocities and the consequences of war on children, on civilians, and it's fatiguing when, you know, between X date and X date, X number of X were injured by X. Why is it so important to have the most truthful data possible? People sometimes question me about the ethics of conducting research in conflict settings. And while I guess that depends on the content of and sort of superfluousness of what you might choose to study, and of course, acknowledging that the ethical ramifications of how research is conducted in those environments is magnified, I think the moral imperative to do research in conflict is stronger than ever, because one is tasked with doing the most for the most with the least imaginable. Next slide, please. We have quite a robust understanding of combat casualty care thanks to incredible efforts from militaries of many different countries in the 21st century, particularly from the wars in Iraq and Afghanistan. Unfortunately, as many say, medicine is the only winner in war. However, there's only so much of this information that can be translated to our context here today, children in conflict, because the demographics of modern conflict, meaning civilians, women, children, are not, you know, uniformly healthy young men protected by body armor. Next slide. So thanks to the Department of Defense Trauma Registry and the military and other shared and uniform trauma registries that were created by various militaries, actually some of the best data that we have on children in conflict comes from those sources. However, as everyone on this call will know, it is very different caring for an injured child within a local healthcare system than within a well-resourced military trauma system, even if that military trauma system is operating in a resource-scarce environment. Similarly, unlike civilian trauma registries, I'm using the one from the United States. I know there are many others. No equivalent registry exists to understand the needs and injury patterns of children in conflict globally. Next slide. As a far from second best, we undertook an effort to pool all of the published data on civilian conflict casualties in the 21st century. First of all, slightly over half reported information on the age of the injured. But of those, we can see that approximately 35% were under the age of 18. Sometimes people say, well, you know, the demographic curve of lower resource countries, low and middle income countries is heavily shifted towards the younger population anyway. Well, it's not normal that children would be as exposed to the harms of conflict as any other sector of the population, including combatants. That's not something to be accepted based on demographic statistics. Next slide, please. It's also relatively easy to find a number to substantiate something you want to say. And I kept reading all over that children had a higher mortality rate in conflict, but the actual reports that I was reading did not necessarily corroborate that. So from that study, we took a subset of the pediatric data, and we found that overall, the mortality rate wasn't dramatically higher. Again, all kinds of problems with these data in general. We could have a separate webinar on that. But in this sample, overall, children had an 11% mortality compared to approximately 10% among adults. But what we did find as significantly different were several subsets, specific patient populations, which I'll get to in a second, and also that a significant proportion, a significantly increased proportion of children were injured by blast mechanisms, emphasizing the importance of the work by Paul and his colleagues. Next slide, please. What can we say about different sexes? So this is definitely a research topic that I'd love someone to get in touch with me about, because I think there's a lot to be done here. I've selected only one report here, but there are several reports, all of which are drawn from military literature, suggesting that injured female children, female with conflict-related injuries, have lower survival. In this particular report, approximately 67% chance of survival compared to males with similar injury severity. And concerningly, also a lower likelihood that they underwent life-saving pre-hospital interventions, so in this case, tourniquet placement and imaging studies on arrival. I think problems like this highlight the ways that other specialties, qualitative researchers, sociocultural and local perspectives are going to provide insight on why that might be, elucidate the reasons for this, but it's certainly concerning. Next slide. So I said that there were some subsets that did have dramatically increased mortality, and those subsets are the youngest children, children under 5, children with war-related burns, and children with head injury. Now that describes a fairly classic injury pattern that children who have sustained blast mechanisms might have. I should also say, though, as horrific as a 30 to 40% mortality rate is, actually adult civilian survivors not survivors, victims of blast mechanisms and explosive ordnance in low resource settings have an approximately 30 to 40% mortality rate regardless. And it's always important to remember survivorship bias in all the numbers. You can stay on that slide, is fine, but it's always important to remember survivorship bias, meaning many of the numbers we have don't reflect the full mortality toll because they only represent the patients who lived long enough to reach care or reach anywhere that their injuries could be registered. Highlighting the burden is a bit of an awful word to use because it suggests that it's a burden to care for injured children, but I mean the stress posed to fragile health systems. Children require intensive resources, including longer hospital lengths of stay, more frequent trips to the operating room, and more frequent ICU admission. Next slide. And I have only barely touched on indirect deaths. I touch on it in this slide. So I've been discussing direct conflict casualties. Meanwhile, this is one geospatial analysis, which estimates that approximately 3 times more, there are 3 times higher rate of infant deaths from indirect conflict-related deaths than direct casualties. Next slide. Okay, why? How is it possible that these numbers can exist? Next slide. Partly a consequence of modern weaponry. Explosive weapons in populated areas are by nature indiscriminate. This is just one example in Syria, where over a 5-year period, you can see the rise in death among women and children. Of barrel bomb deaths, about 8,000, 97% of those were civilians and over a quarter children. Next slide. Also, children are curious, so they're significantly more likely to be handling explosives at the time of injury. You can see this butterfly mine on the right, which looks like a toy. Also, these frequently occur as mass casualty incidents because children play together. In one data set from Iran, about 60% of incidents occurred as mass casualties. Next slide. it's not just, I mean, it's hard to call the use of explosive weapons in populated residential areas passive, but it's not even just the indiscriminate effects of those munitions, but active targeting, as unfortunately is depicted here by an improvised explosive device rigged to a teddy bear. This was during ISIS retreat from Raqqa. Next slide. Similarly, children are recruited as combatants. This is a long-standing practice, but the atrocities are exaggerated, I would say, by non-state armed group recently, such as the unfortunately named Cubs of the Caliphate, which is ISIS in the top right corner. 90% of their child recruits are used in combat roles, and children under the age of 5 used to have been publicized in propaganda material, committing executions, etc. Next slide. None of this takes into account pre-existing vulnerabilities. So children with disabilities, first of all, I hope that someone else will touch on the MRM, the mechanism for reporting the grave violations against children. However, while causing disability is one of them, pre-existing disability is not taken into account. Children with disabilities are incredibly vulnerable in conflict. They're recruited as suicide bombers. Their health conditions cannot be sustained when they have chronic health needs and the health infrastructure and food supply breaks down. And this was a tragic case. For the photograph is from the New York Times in Gaza. Next slide. The consequences, I think other speakers will touch on, but briefly, physically, frequently inadequate access to prosthetics, frequently outgrow their prosthetics, require more frequent operative intervention after amputation to address problems like bony overgrowth. Educational, this girl in the middle panel, in a high resource environment, that particular amputation would not pose significant challenges for her educationally, but you can see her colleagues on the right, her schoolmates, having to carry her whiteboard to her every day. And of course, psychosocial, I'm glad there's a talk on today. Next slide. This photograph is dear to my heart, and this is a little boy that I love here in Burkina Faso, where I live and work. I found him begging in the street. He has a congenital disability. He has one leg, and he has a grand total of 2.5 fingers. And this is his school book. He just started, and this is his writing, and it's better than mine. So as sickening as a lot of the numbers I shared are, I like to remind myself that children have a lot of joy and beauty and capacity within them, no matter what their circumstances. And it's our responsibility to do absolutely anything we can to support them. Thank you.
Thank you so much, Hannah. Some really eye-opening and alarming statistics there along the way. We were due to move on to Dr. Nashra Al-Deeb.
She is online, actually. Apologies, she is online.
Oh, she is online. Okay, fantastic. Okay, so yes, we'll hand over to Dr. Nashra Al-Deeb now for her talk about nutrition programming for children during conflict.
Thank you, everyone. Good morning, afternoon, or evening, depending on where you are. I'm Dr. Nashra Al-Deeb, a physician and a public health expert with over 20 years of experience in the field of public health in both developmental and emergency contexts. Next, please. Emergency trends have significantly increased over the last few decades. I have highlighted here 2 areas of concerns for nutrition: the conflict in general, armed conflict, and climate health disasters such as floods, droughts, and extreme temperatures. These emergencies have far-reaching impacts, disrupting, including health, nutrition, and water and sanitation, hygiene, and social protection services. They also this emergency destabilize food system and supply chain, affecting food availability, accessibility, and utilization. Next, please. Emergencies drive displacement And we could see as well displacement has been increasing over the couple of the last couple of decades. And this disrupts the livelihood, leaving families more vulnerable. And this impacts children who face a heightened risk of malnutrition, poor health, and limited access to critical support system. It impacts as well their children's breastfeeding and complementary feeding practices. We could see even the concentration where millions of displaced families are concentrated around those areas that are prone to emergencies or prone to emergency. Next, please. Here we could see there is an increase in the number of people requiring humanitarian assistance throughout the years. And in the same time, access to affected population is limited due to insecurity, damaged infrastructure, and administrative barriers. And then hard to reach areas are being now more common, and they experience delayed or insufficient nutrition interventions. This making pregnant and lactating women and children more prone to worse impacts, and the fact that pregnant and lactating women and children biological need for pregnancy or growth for children lead to higher risk of mortality. Next, please. The nutrition situation globally is dire as it is, and emergency is just worsening the situation. So globally, we know that more than 150 million children, or approximately 20 to 25% of under 5 children, are impacted by stunting, which has profound long-term consequences on health, education, and economic outcomes. We could see 4 out of 5 children affected by stunting live in South Asia and Sub-Saharan Africa, where most countries are prone to emergency. And then we see as well over 45 million children are affected by wasting, with 1/3 experiencing severe wasting. That is 1 in every 3 children suffer from severe wasting. That is 11 times the risk of mortality compared to the normal child. The global number of children under 5 affected by overweight has increased as well over the years, from 30 to 38 million in the last 2 decades. And 1 in 4 children are living in severe child poverty in early childhood, around 181 million children under 5 of age. So trends indicate that current progress is insufficient to achieve the World Health Assembly Global Nutrition Targets 2025 and the SDG goals and targets for the reduction of child stunting, wasting, and overweight. Next, please. So as part of the continuum of care, we look at the mother as well. And then globally, we see 1 in 10 women are too thin. More than 3 times as many women are affected by overweight. Anemia affects 1 in 3 women, and further, each year about 20 million babies are born too small. So as I have highlighted earlier, the situation is already dire as it is, and the conflict is only exacerbating the nutrition situation of children and mothers during emergency. Next, please. Now, this is just to see, I have already highlighted earlier, but there are so many triggers, and these triggers, including conflict, has an impact on the population and the family, at the family level and at the individual level. And this could disrupt the services that were provided, the quality of the services, the availability of services or food in general. It shifts people's behavior into coping mechanism, eating 2 times or 1 time a day instead of 3 times a day, shifting to cheaper products that might not be healthy for children or even for the family as a whole. quality of water is an issue, and so on. All of these has an impact on nutrition. And as a public health concern, we need to think about prevention, preparedness, even before the emergency response, and we will talk a bit later on that. Next, please. So once an emergency happens, what is it that is expected from us or from the nutrition community? Strong coordination among nutrition, health, and WASH sector and food sector as well is needed, because malnutrition is not a one-sector job, and there is a need to have capacity in place to coordinate properly and make sure aligned response. We need robust data collection system in place for real-time nutrition assessment, and we need a monitoring framework to regularly monitor and analyze our response and to guide our intervention or to rectify based on the analysis. And then we need to establish or continue or even scale up our nutrition services based on the need assessment. And this services should be around protecting and protecting the children and preventing malnutrition and treatment if there is a malnourished child. So moreover, we need to think about how to integrate with the health system, as I highlighted earlier, in terms of continuum of care as well, integrating nutrition care into healthcare services for early detection and timely referral and intervention, and provide antenatal care for pregnant mothers, and offer nutrition counseling in general. Moreover, we need to improve the system or work in a way that strengthens the system to sustain or to scale or even to establish these services. We need to enhance the capacity of the health workers and not to forget to implement social and behavior change communication strategies to promote healthy nutrition practices and to involve communities in designing and delivering nutrition interventions that are culturally relevant and acceptable. Next, please. And now, as I have highlighted, it's based on the assessment, what the package of services is, but we need to think of comprehensive service package. As I said, it's a nutrition is a multisectoral, malnutrition is a multisectoral disease, and in emergency, we should consider that, and we should consider the fact that the child and the caregiver are seen as a unit, recognizing that the well-being of one is deeply intertwined with the other. The holistic approach ensures that both immediate nutritional needs of the child and the caregiving environment are addressed simultaneously. There is more and more now focus on looking at the child as looking at the child with the caregiver, and the fact that the caregiver is under stress, needs psychosocial support, is thinking about where to get the next meal, impacts the responsive feeding and the stimulation of the children, and that's why it is important to look at them as one unit. Next, please. I have just highlighted here 2 examples, and just to give you a glimpse, there is a lot that has been done in Yemen and in Ethiopia, and I just want to highlight key point that I felt it's important for this webinar. But you can always read, there are so many resources for Yemen and Ethiopia where a lot of work has been done. Yemen has been facing a protracted humanitarian crisis for several years, with the situation worsening in the conflict following the Arab Spring. And Yemen had the good thing, even after the Arab Spring conflict, Yemen had already an existing cluster coordination mechanism in place. They had emergency response plan in place with scenarios, targets, strategies, funding requirement that is done by cluster partners. They had a strategic advisory group and technical working groups already in place to support the implementation. And for the technical working group, there was wasting, IYCFE, and assessment technical working group that partners were fully engaged in, and nutrition cluster worked closely very well with other sectors, health, food, WASH, to converge they coordinated for assessment and even for targeting and for response for convergence. For example, even in the assessment and the multi-cluster initial rapid assessment MIRA, nutrition was integrated in the assessment. They have now several smart surveys, integrated food security phase classification conducted to inform the response. And the key features for the Yemen response is to focus around management of wasting and infant and young child feeding. For Ethiopia, social protection was included and community platform was highlighted as a platform of delivery to reach more. I'll leave, next please. I'll leave Ethiopia. I just want to highlight that in Ethiopia, the good thing that there was a lot of focus on the food system and community engagement for more reach. Next, please. Yeah, the key message that I want to leave here, that preparedness is a key. There are so many emergencies in the world, and the scale of emergency is not scaling down. And we need to invest in nutrition preparedness because that child dignity and that child life matter. Over from my side.
Thank you so much, Najwa. Absolutely fascinating insights and really important key messages. Just a reminder, everyone, if you do have any questions, please pop them in the Q&A box and we will try to answer them at the end. Any of the speakers who are unable to take questions due to not being available at the end, we can pass them on as well to be answered for you later. So we'll progress on now with a similar topic where we're going to look at some essential critical care for malnourished children with Dr. Hans-Jörg Lang.
Yeah, hello. Can you hear me? I quickly try to share my screen.
Yes, we can hear you. If you pop your camera on as well would be, if you can. Great. Wonderful.
Can you see the screen?
Yes, we can, Hans.
Okay, yeah, so thank you very much for inviting me. So I will talk briefly about a structured approach to the care of a critically ill malnourished child in low resource contexts. I'm not a nutritional specialist, so I'm just a clinician in pediatric critical care. I also want to highlight that on the 18th of February, via the World Federation of Peds Intensive Care, we will have a nutritional online workshop where we can discuss more in detail nutritional aspects of critically ill children treated in low resource and humanitarian contexts. I also would like to acknowledge advice from various colleagues. So Najwa already discussed the increasing number of child victims during conflicts. There are direct and indirect effects of conflicts which can be long-lasting. Displaced populations face particular vulnerabilities Amongst them, also limited access to essential healthcare services. Overall, global child mortality decreased over the last 30 years. However, in areas exposed to conflict, child mortality, under 5 mortality, still remains extremely high, with examples like in Chad, around 100 per 1,000 children under 5 dying before reaching the age of 5 years. Neonatal mortality remains high, and as Navia already explained, a large number of childhood deaths are associated with malnutrition. Main causes in the under 5 group, main causes of death are acute infections, sepsis, malaria, respiratory infections. Important for humanitarian programs, child health includes newborns, children under 5, malnourished and non-malnourished, and also the children above 5 years, adolescents and young adults. Now I discuss the different wider determinants of child health and complex aspects around nutrition. In this context, access to essential pediatric emergency and critical care also plays a role as part of a universal healthcare coverage. And in this context, it's important to look at referral pathways. How can a sick child access care from a community to a peripheral health facility to a district or regional hospital? And along these pathways, we have different guidelines and definitions of standards of care by WHO, international organizations. Important, after the acute care, we need to look at post-discharge support. An example, Mariam lives in the Lake Chad region, is 3 years old. She had fever for 3 days, became increasingly lethargic and had a few watery stools. This morning she had a convulsion. The mother rushes to the hospital. On arrival, she has a partially obstructed airway, some secretions. She has signs of respiratory distress, shock. She's pale, not dehydrated. She responds to pain and has intermittent convulsions. Her mid-upper arm circumference is 112 millimeters. So health facilities should be set up to do triage. And our child, Mariam, certainly is a red case, so needs immediate emergency treatment. So linked to the triage area, we should have an emergency setup and an essential critical care unit. And the approach to a sick child, in this case with severe acute malnutrition, is following WHO guidelines, ETAT, Emergency Triage Assessment and Treatment. Simple, but very useful. So a structured approach with airway, breathing, circulation, neurological complications, and then a head-to-toe examination. And further, essential critical care. To provide this care, we need adequate equipment and setup. Child and parent-friendly health services is something we need to do. It is as important as airway, breathing, circulation. So an important element if we set up health facilities or support health systems. Our child is breathing. She has difficulties. There's respiratory distress. She's placed on oxygen. And our SpO2 target is a SpO2 above 94%, as she has multi-organ dysfunction. Theoretically, in a district hospital setting, we could also set up some bubble CPAP if we have adequate expertise and resources. Mechanical ventilation is not a priority in these scenarios in a district or regional hospitals, and it should only be done if we have adequate resources and expertise. But at least we should have oxygen in the bigger health center in a district regional hospital. WHO defines O2 as an essential medication needed for emergency care, safe anesthesia, safe surgery. But the reality is that in many hospitals, for example, in sub-Saharan Africa, we do not have reliable O2 infrastructure and not reliable electricity systems. There are different forms of oxygen we can provide to set up a decentralized oxygen system. For example, oxygen concentrators. We need maintenance and repair systems, and we should have electricity. Doesn't sound very medical, but in order to provide adequate care, we need to have the right logistic setup. Solar systems can be cost-effective and technically reliable and can provide adequate electricity for oxygen systems and other biomedical equipment, including cold chain. So we cleared Mariam's airway. She's on oxygen. The SpO2 monitor doesn't give any reading. She shows signs of shock. She's pale. Her hemoglobin is 5.9. There are no signs of dehydration. She responds to pain. So to improve her respiration, we can prepare some bubble CPAP while we continue with our circulation assessment. Her central pulse is palpable but fast. Peripheral pulses are weak. Her cup refill time is prolonged and the extremities are cold. She has signs of shock. What else do we need to know? She's pale. In this case, she doesn't show any signs of dehydration and she's malnourished. That's important for our fluid management. WHO defines shock in the malnourished, non-malnourished child if all these three signs, prolonged cup refill time, cold extremities, weak pulses, are present. If only one or two of these signs are present, it's still a danger sign, but we wouldn't give any fluid resuscitation. Treatment of shock follows the simple principles. Airway, breathing, we can start oxygen, we can get IV intraosseous access if we can, and we can give a fluid bolus. Slowly, we need to be careful with fluids and avoid fluid overload. If the child shows signs of shock and severe anemia, and here we talk about a non-trauma scenario, in this case, we would not give a pre-transfusion bolus. We need to get a blood transfusion. WHO describes different clinical scenarios for treatment of shock. No dehydration, we can start with 10 milliliters per kilo slowly. If the child doesn't have severe acute malnutrition, but severe dehydration, we can start a plan C. But careful, it's a lot of fluid and we need to monitor the child carefully. So let's not fluid overload. That's very dangerous. In the malnourished child, we are more careful. We may give 15 mL per kilo of isotonic fluids, for example, Ringer's lactate with some dextrose over 60 minutes, so slowly and not so much. Which fluids should we give? Simple, we give isotonic crystalloids. Ideally, they are electrolyte balanced, but let's say that's a detail. Can be important, but a further discussion. There's no benefit to give semi-synthetic fluids or colloids like cellofusin. And actually, there's an increased clinical risk in their use. At the moment, we also don't have any evidence that human albumin solution is of any further evidence as compared to crystalloids in this setting. So let's stick to isotonic crystalloid solutions, ideally electrolyte balanced. Our child is severely anemic. So important on district, regional hospital level, we should have a blood bank for trauma cases or children with critical illness due to medical conditions. The WHO transfusion target in this context is 6. Is this too low? Well, maybe for some patients. So that's open for future debate and research. Child with no severe acute malnutrition should receive 15 to 20 mL per kilo packed cells or whole blood, slowly over 3 to 4 hours. Important, this is not a trauma scenario. In severe acute malnutrition, we give less volume, 10 mL per kilo, also slowly. We should keep monitoring hemoglobins as we may need further transfusions. If we can't get an IV line, we should have intraosseous access.
Hans, I'm just going to give you a quick one minute warning, if that's okay. Sorry.
Okay. Yeah. So can we make 2.5? I'm quickly through. Okay. So fluid management, we monitor carefully, we avoid fluid overload. I will not go into details on starting vasopressors, not a priority in a district or regional hospital. We can provide good care with essential measures. Our child is improving, receiving a blood transfusion, being on oxygen or CPAP. Her blood sugar is low and she has convulsions. We should correct. And the new guidelines show that it's 3 mL per kilo of dextrose 10% these days. If the child keeps convulsing, we follow an status epilepticus algorithm as you know it. A little detail, as a second-line anti-seizure medication, levetiracetam may be of use as it doesn't have any respiratory depressant effects. We review the child. We do point-of-care tests like malaria, and if needed, we start anti-malarial treatment and add broad-spectrum antibiotics. The child is stabilizing, but not tolerating enteral feeds. So we can start maintenance fluids, the 4-to-1 rule you may know, and we can give it carefully, maybe only 70% of the calculation. It should be isotonic fluids with dextrose. And now I'm almost finished. So when do we start enteral nutrition? And this is important. The child is just being stabilized after having respiratory problems, signs of shock. So we cannot immediately start nutritional rehabilitation. We can introduce stepwise enteral nutrition in case of a severely acute malnourished child or in case of a critically ill child without malnutrition. And this we can discuss further, as I mentioned in the webinar on the 18th of February. If the child is now stabilized and tolerating enteral feeds, waking up, improving, that's the time when we can start then nutritional rehabilitation. So that was a quick run over the treatment of a child living in a conflict area with severe acute malnutrition and critical illness. Thanks for your attention.
Thank you very much, Hans. Absolutely fascinating. And I apologize that some of these talks may seem a little bit short. Hopefully later in the year, we can organize some webinars where we go into greater depth in some of these topics after this wonderful brief overview of them all. So thank you very much, Hans. We're going to move swiftly on to Dr. Amathano Alessa over in Syria to hear about the struggles of adolescent mothers.
Thank you. Hello, everyone, and good afternoon. I'm very happy to be part of colleagues who are speaking in this session. I'm Dr. Al-Muthanna Al-Isa, SRH coordinator with Care International in Turkey for Syria response. Where I will talk about a marginalized group suffers from difficulty in obtaining medical healthcare services. As you see, where adolescents have unique needs, even in stable settings, in humanitarian settings, their needs not only continue, but also increase. Adolescent in emergencies, often separated from the social support structures that they rely on in the stable settings, such as parents, peers, and teachers, and their barriers to information and services. Furthermore, in the humanitarian setting, they are usually forgotten and invisible. Adolescent girls in particular are vulnerable to increased levels of risks, including, as we see like in the pictures, like limited access to health services, high risk for forced recruitment to armed groups, high risk for sexual violence, additionally, high risk for child marriage, losing family, social education, and religious structures. Next, please. Yeah, so according to this, Care International, in cooperation with other like UNFPA and other NGOs, started to adopt AMAL initiative, which is Adolescent Mother Against All Odds, based on the Syrian context. As we like have seen in Syria since like 2016 and 17, in the Syrian context, high rates of child, early and forced marriage and subsequent impacts, increasing in adolescent pregnancy, increasing in negative psychosocial impacts, barriers to accessing health services, also increasing in challenges in negotiation with gatekeepers like fathers, mothers, brothers, and husbands, increase unmet needs for services and information, the need for a special approach to address the unique needs for this group, especially adolescent girls at increased risk. For example, pregnant adolescents, lack of consultations with participation and engagement with adolescents in the design of projects that affect them. Safety and security concerns regarding the lack of safe spaces for women and girls. Next, please. Providing such services in Northwest Syria contexts, it's provide unique needs and barriers faced by adolescents in crisis settings, building on care expertise, not only on SRH, but also on the transforming gender and social norms. CARE BSRD developed 3 components to meet the unique needs of this population. Goal is to improve access to SRH services, including deliveries by skilled birth attendants, and support healthy timing and spacing pregnancy. If we can see in northwest of Syria, this is since like 2017-18, 37% of the affected population requires routine reproductive health services. 57% of the communities reported child early forced marriage, increased levels of child early forced marriage, lack of meaningful access for SRH services for women and girls. SRH is not seen as a priority among the health actors. Service providers' attitude towards GBV survivors, adolescent girls, increased level of GBV, restricted mobility of women and girls. Currently, this is like since 7 years ago, more than 630,000 adolescent girls, they are living in northwest of Syria. Next, please. So according to this, AMAL initiative is an approach for meaningful participation for pregnant, adolescent, and first-time mothers in crisis settings to improve their sexual and reproductive health. Why? Because child early forced marriage is increasing as a coping mechanism. Adolescent pregnancy is very common in Syria. How can we mitigate risks related to adolescent pregnancy? Services are not adolescent responsive. Next, please. So, according to the theory of change, here, as you can see, the problem is, like this is like the tree problem and the solutions. The problem is, in crisis affected and fragile settings, adolescent girls are especially vulnerable to poor health outcomes because of increased risks of early marriage, early pregnancy, and reduced access to life-saving and reproductive health services. So the strategy was implementing AMAL initiative with 3 components: Young Mother Club, Community Social Analysis and Action, Health Service Providers, Social Action and Analysis. The activities, they are structured sessions for each component. The output, it will be delivery by skilled birth attendants, also a creation of community-led actions plans to address inequities in gender and power, also improved attitude from the health staff toward family planning provision to adolescents. The impact, it will be like increasing agency and leadership of adolescent girls, improved the relation with the community and health providers, transformed structure through adolescent responsive services and environments. And the vision and the long impact, it will be improved sexual and reproductive health and well-being of adolescent girls through advancement of equitable gender, social, and power norms in the fragile context. Thank you. Thanks everyone for listening, and please let's stay in touch if you have any questions. Thank you, and over.
Thank you so much, Dr. Al-Muthana. It's a fascinating subject, and lots of questions coming through about it, which I understand we might have to get an indirect reply later on. So we'll try to get that sorted for everybody. So moving rapidly on as we move into mental health considerations with Arijbu Rezlan. Thank you very much.
Thank you so much, Dr. Chris. Can you hear me properly?
Yes, absolutely, loud and clear.
Perfect, thank you. Hello, everyone, and thank you so much for having me on this webinar. My name is Arijbu Rezlan. I am a clinical psychologist and mental health and psychosocial specialist with over 20 years of experience in both conflict and development context. But really, for me, what I would like to say, and based on everything that my colleagues have expressed, is children in conflict, unfortunately. No, can I stay with the other one? Yes, thank you. Do experience lots of losses and disruption to their normal lives, and sometimes even lack of access to basic services like health education and livelihood. So it is very common for these children to experience varied degrees of distress that can definitely have both short-term and long-term effects. And it's really what I would like to say is all of us in all of our positions, regardless of our sector, we have a role to look after these children and have a therapeutic lens. So we're not talking about offering therapy, but we're talking about some mental health considerations that's very important for us to keep in mind whenever we're working with children. I just want to refer to the Paediatric Blast Injury Field Manual that Dr. Powell had mentioned at the beginning, and there is a section that specifies in more detail some of these considerations, including some of the common stress response that children have and how medical staff can do to respond to them, including do and do not, plus tips to caregiver. But at the moment, because of the shortage of time, we're just going to go very quickly onto some of these key considerations. Next. So I'm not sure how many of you are aware of this pyramid, but this is the MHPSS, or the Mental Health and Psychosocial Support Intervention Pyramid. And what it really kind of explains that the majority of people and children will usually be able to bounce back and recover without any specific mental health intervention. But what we really need to ensure that their basic services and securities are met, but with an important condition that there are social consideration when we are looking at these basic services. And what does social consideration mean? is we have to really ensure that these services are given in a very dignified way, that people, their voices are heard, that there is a participatory approach, that we are looking at from a gender, age perspective, and definitely abilities. So it's really important to think that the majority, again, of people will really bounce back to be able to recover and heal. And then with the pyramid, you will see later maybe another, more people might need an extra support with community and family support. And this is where, for example, we're talking about child-friendly spaces, sometimes with the women support groups, till we reach to the end of this pyramid, where very little percentage of people who might need more medicalized or specialized services. Now, the pyramid also explained to us, or let us understand that actually, that not every child who is exposed or have experienced traumatic event is traumatized. Because I think sometimes we use these words very lightly. Trauma and traumatized children really has to be defined or give, like a psychiatrist or a psychotherapist will say this child is traumatized, but most of the people and most children will definitely have acute distresses. And that's, for me, very common for such a horrible sometimes event they have. But just for the first thing, to make sure that we're not talking about traumatized children. And as we said, many of these children will heal when their basic needs, including definitely protection and ensuring that they are in an environment that is safe and they are back to their routine and their, having friends and predictability. The other thing, it's also important that when we talk about mental health and psychosocial considerations, that we need to recognize and build on the capacity of and resources of people. So people do really are resilient, and there are a lot of resources in the places where we're working. So it's very important that we tap on and we don't create parallel intervention or parallel ways of support. And the last important thing, that again, when we're talking about the pyramid, or the pyramid of intervention, that there is a continuum care and multi-layered support. So remember, people are one. It's especially children. We sometimes tend to dissect because we work in different sectors, but really, if we think about any intervention as all of these should support the well-being of these children, it's very important that we work in a very holistic ways across this pyramid. Some children will definitely need some basic services, but at the same time, they might need to be referred to more focused support or clinical services. So it's just very important to think more holistically. Next. So now some of these consideration or key consideration when we're working with the children, the most, and there is no order in these ones, they are all important. It's very important that we relate to children according to their age and developmental stage. And what does that mean? Is we can't really talk to children or respond to them in the same way. A child who is 3 or 4 years old, their understanding of their environment and what, or understanding also what's happening in their life will be different than a child who is 13 or 14. Some children, especially that they are younger, with their egocentric kind of way of looking at life, they might blame themselves or think that they've done something wrong, so they're punished. So again, their way of processing and responding will definitely be different. So again, when we are working with children, it's very important that we understand that their age and their developmental stage will be determining how they are responding, and also how do they talk about the event. So just make sure that whatever you are communicating with, to keep that in mind. Now, and again, in a very medical setting or in a place where we are working with children, some basic things, when you're working with a child, it's very important that you introduce yourself, again, in a way that the child can relate to. It's very important that you explain what you're doing, ask about the name of the child, and understand what are the concerns of that child and what they might need. And it's very, really important that you stay calm and help the parents as well. To stay calm and to comfort those children. The other thing is avoiding separation. It's really important for children, when possible, to really be with their caregiver or people that they know. Sometimes we receive children who are already unaccompanied. It's very important that we have a referral mechanism to be able to join these children with their caregivers. Again, especially in places where the child is in a hospital, or in a place where they need that support, they should be with their caregivers. So again, part of the key consideration is you work with the child protection working groups, or at least have a mechanism in place. Again, that's regardless of the sector that you're working with. The other thing we're talking about, show children respect. And when we talk about showing children respect, that's really very much related to ensuring that they are, their dignity is safeguarded at all times, that we listen to their fears, that we do not shame them, about how they are feeling or what they are saying. I know in some contexts, sometimes, unfortunately, we expect children to be brave and, to hold on or to play some roles. But it's really important that if a child, no matter what's their age, if they are expressing certain doubts or certain fears or emotions, that we respect that and support them through it. As I said, as well, part of the respect is to respect and remember that children have their own strength, and really help them regain control over their functioning. So it's important, again, when we are taking some decision, again, based on the age of the child, to involve them in some decisions, especially with children who are older. It's important that we can offer them some strategies for calming themselves and finding what kind of strategies maybe they have used in the past that usually work for them. It's important, again, when we talk about respect, that we take consent from the child. Again, depends on the age, but for very little children, that you take consent from the parent. And lastly, in terms of respect, it's really important that we explain to the children in a very simple language what will happen, and allow them to ask questions, especially if we're talking about, let's say, medical treatment, or in terms of in blast injuries, what is the process and procedure. Sorry, when we're talking about key considerations, again, caregivers play a very, very important role in the mental health and well-being of the children. We can't separate children well-being without really looking at the caregivers. So it's very important that we support the caregivers as well, to be able to express their doubts, their fears, and be able to have some really very clear explanations on what's happening to the child. Children will not recover without the support of their caregivers. Now, again, if we look at with the manual, the blast injury manual, you'll find there are some tips, including, for example, providing very simple leaflet of explaining what's happening, and some tips of some of those reactions that a child have. But again, if we understand sometimes the age and developmental stage of a child, if a parent coming and explaining, oh, my child who's 7 or 8 years old, and they started again maybe bedwetting, or they sucking their thumb, we can really assure them that these are very common reactions to the children of the children who have experienced very distressful events, and with the support that these reactions or these responses will go. Sometimes the parents really, really worry about their children when these, again, reactions are very common. So again, our role is to understand some of these responses that the children might show, and to support the caregivers on how to care for the children. The last two things really about creating a child-friendly and healing environment in general, wherever we are, when we're working with the children. And my colleague later will talk about the importance of play, but children really need a space to be just children, where they can express their emotion, they can play. So if we're talking about, let's say, a hospital or a primary health clinic, or even a nutrition place, it's very important that we can really create a place where children can draw, they can paint, sometimes just give them some of the stethoscope or something that are or syringes without the pin or the needle, that they can really play with them, and that can comfort them in the process of healing. And the last important really thing is taking care of yourself. you play a vital role in looking after children and supporting them. And most of the time, witnessing the suffering and the pain of other people and children and the grief and the loss will definitely will cause distress to you. And we know we work most of the time in a very challenging condition. So it's really, really important that you look after yourself, not only in the order to look at, to best care for the children and their care, but really to preserve your own health and well-being. And that's it. Thank you so much.
Thank you for that wonderful presentation, Ari. We have some questions lined up for you at the end if you're going to be free, and that would be fantastic. Moving along with the same theme of children and play, we're going to go to Dr. Alexandra Glosh.
Hello, everyone. It's a pleasure to be here. Thank you very much for the invitation. So my name is Alexandra, and I'm from background lawyer and philosopher working at the Pontifical Catholic University in Chile. And I'm sharing my screen now, and I'm not sure if you can see it. If you could confirm that.
Yes, we can see it, and we can hear you loud and clear.
And is it changing? The slides are changing also too.
It is indeed.
Yes, or yeah, okay, thank you. Thank you so much. Okay, so I'm going to speak about play and its contribution to recovery and reintegration of children coming from violence, conflict settings. To begin with, what I find most valuable about play in this context is that, as UN Committee on the Rights of a Child very aptly put, it opens a natural, self-guided and self-healing process of trauma recovery, and a process where children can become protagonists in their own healing stories and also possibly even agents of peace for their violence-stricken communities. So in this presentation, I will explain mechanism behind this therapeutic and peace-building function of play. And while doing so, I'm going to refer to preliminary findings of a research which, together with my team, we have conducted lately among children, migrants and refugees in Chile. So before entering the topic of play, I wanted to say 2 words about this endemic and quite explosive mix of political, social, interpersonal violence that children, migrants in Chile have to struggle with. So majority of children in our study were from Venezuela. And with unexpected openness and political awareness, they were sharing with us stories of poverty, crime, danger, all types of difficulties. And for example, we learned that children who dared to, under the present Maduro regime, children who dared to share some anti-governmental content on social media ended up being kidnapped, imprisoned, tortured, etc. Unfortunately, after arriving in Chile, the life of these children is far from being safe havens, as they reside in rather challenging neighborhoods permitted with all types of Latin American specific problems, the worst of which is, in my opinion, the always present danger of criminalization of children themselves. So, for example, in the school where we conducted the research, children were both victims and perpetrators of all types of crimes and abuses, including even armed clashes between children gangs. So in the middle of this hard life, as one child in our study put it, play is something very, very important. First, for the dignity of his children and their joy. There is this phrase by Van Gils, which I particularly like and almost obsessively cite, that play is a child's right to be a child. With children in our study, these very special children who combined childlike joy and trust with sometimes almost adult-like maturity, understood very well in saying, for example, that they need to play in order to have a childhood. But beyond this intrinsic value of play, which is crucial, it has also countless instrumental benefits for children's physical, social, cognitive, emotional, and even spiritual development, which children in our study understood also with astonishing clarity. So, for example, one of the first dialogues that we had with children is this one, where straight ahead in the second sentence, they told us that they need to play not only not to get bored, but also not to become sick. Also for their cognitive development, for their social development. And when asked to explain the importance of play for their health, children also mentioned its various dimensions. So, for example, physical health, not being locked up, mental health, not getting stressed, and social health, meeting more than only one person in life, which, by the way, is quite interesting finding in itself, that children somehow intuitively and very wisely adopted the wide holistic notion of health. But undoubtedly in this and all subsequent dialogues, children put the strongest emphasis on the importance of play for their mental health. And we could distinguish various themes, various channels of this influence. I'm going to mention only two of the most straightforward or most important. So first is all the fun, all the positive affect, all the happiness that play produces, and thereby helps children to cope with challenges of their everyday life, and in some cases, in our study, evident mental health problems. Secondly, and very importantly, play is an important factor of building stress resilience, which it does not only by diminishing children's stress, which we constantly repeated in our study, but also quite paradoxically by exposing children to stressful situations, but doing so in the same as safe as if playful frames, and thereby allowing children to develop strategies, sophisticated strategies to face these challenges also in real life. And speaking of therapeutic potential of play, I wanted to mention a quite symbolic fact that it was first discovered in the context of extreme violence and trauma, namely after the Second World War, where the first psychologist at the time discovered that children of war very rarely speak about war, but almost as a role play it. Playing, for example, air raid games where children have to skillfully run into hiding places as if under bombing. And the most heart-wrenching example that I ever heard, but at the same time the most telling one, is about children of Auschwitz who, as Eisen report, did not want to play all the fun distraction games that their parents, if present, were proposing to them, but they preferred to act out their own deaths in a game called We Are Going to the Gas Chamber. So these disturbing examples show very clearly that play is a language of children, a language through which they express, elaborate, and make meaning of a difficult experience, thereby also getting a chance to heal it. And one example of such a play from our study was given by a mother, because later we also interviewed parents of his children whose son was making meaning of all the moral explanations that she was constantly providing to him in a recurring theme of his plays when he was a policeman fighting off crime, which in this environment where, as another boy in our study put, people do everything they can not to fall into gangs and drugs, becomes quite symbolic and very, very important. And this leads me to a second theme, which is peace-building potential of play. And here the first channel of it, obviously, is all the integrative community-building potential of play. Children, like a mantra in our study, were repeating that they like this or that play because they can play in the team, they can make friends. Important aspect of play as a language of children is the fact that it can become a bridge between different cultures, which in our study manifested itself, for example, in a story of one Venezuelan boy being able to befriend and play with a Brazilian one, despite the fact that they did not speak the same language. But beyond all this integrative, community building, culture bridging, inclusive potential of play, I think that the fundament of its contribution to positive peace is the fact that play for children is an entry into the world of normativity. So, as Jean Piaget classically argued, even the simplest game is a complex social institution with its own intrinsic rules, with its own jurisprudence, and as such, as he put it, it is where morality begins. And I think that it is important that children, while playing, not only learn to understand and respect rules, but which is perhaps more valuable for the democratic, peaceful community of today, they also learn to negotiate rules, modify rules, and solve conflicts where the rules are broken. They also, while playing, learn and train values or virtues, such as obviously fairness, but also, as children in our study many times repeated, respect for the rights of others and patience in waiting one's own turn, for example. And I wanted to conclude with this picture, which, in my opinion, best expresses the miraculous nature of play. And I think that precisely the word miracle is the right one to fully capture the full potential of play, especially if we use it in the sense that Hannah Arendt, one of the greatest philosophers of our time, put attached to it. So Arendt thought of miracles as breaches to the sometimes merciless and deterministic causal chains and vicious cycles of human history, and as such new beginnings to it. And I think that this is precisely what children's play, especially in the conflict zones, is. It's an exercise of freedom, exercise of agency, of children's innocence and their hope, and also an act of resilience too, but resistance, and the protest to the despair and destruction that sometimes govern adult world, and as such a new beginning for us all. So that was it. Thank you very much for your attention.
Thank you so much, Alexandra, and really highlights some of the key points about what being a child should be and is in conflict settings, and some of the great issues that we need to address, and the importance, therefore, of getting together in groups like this. Thanks for all the questions coming into the Q&A box. Please keep coming as we move into our final presentation before the Q&A. Some of the presenters might not be able to answer them live, and if they're not able to answer them live, we will give you a written response later. So please keep the questions coming into the Q&A box. But I'll hand over to for our final presentation to Dr. Gavin Wooldridge.
Hi everyone, so my name is Gavin. I'm part of the Paediatric Blast Injury Partnership, and not a blast expert in any way, shape or form, but unfortunately had a lot of experience in the last 15 or so months. Yeah, next slide. So Hannah's obviously spoken to the fact of how children are disproportionately affected during conflict, and how there's significant difficulties in data collection. But we do know that almost 1 in 6 children live in some form of conflict setting. Almost 450 million children. And although data collection is very challenging, we think approximately 12,000 children are killed every year. But this is probably a massive estimate. And the number 86 there is just to highlight this is probably the number of children that are killed or maimed or suffer some form of violence towards them in a conflict setting every single day. And Hannah's spoken to the fact that children are especially vulnerable for a variety of reasons. And so children are different because they have different patterns of life. They're less able to assess risk. The destruction of essential services tends to affect them a bit more. They're very vulnerable to domestic abuse and gender-based violence, and the profound effect that it has on mental health and their ability to play as also and attend school that we've kind of spoken about already. But they're also, from a clinical perspective, they are not a uniform demographic. They do have slightly different anatomy and physiology. Next slide. And in addition, that most of these centres or areas in conflict aren't really set up for child casualties. So when you think of the space and logistics around all this, the healthcare facilities aren't really designed for children. There's limited scope for children to play or educate. There's multiple children to one bed. There's limited paediatric supplies. There's limited paediatric specific equipment, often lacking in appropriate paediatric medication, or appropriate feeds. When you think of staff, there's very limited pediatric specific training in a lot of these centres, a lot of limited kind of pediatric nursing training as well in particular. The systems in place, we know in a kind of in a major trauma centre, so in a high resource setting, we talk about the golden hour, but in a pre-hospital setting, in a conflict context, we know that transport to a hospital in 1 hour is not a realistic goal at all. And in some studies, that up to 85% of children and people in some studies die prior to getting to hospital in a conflict setting. And in security, finally, especially as we've seen in Gaza, children are often separated from their family members, or indeed the only remaining family member. And this obviously leaves them at significant risk of exploitation and abuse that we've touched upon. Next slide, please. So very briefly, when we think of the blast explosion, hopefully that video I was not going to play. Okay, unfortunately that was a video that shows a blast wave. Sorry, it doesn't seem to be playing. I think if you click on the bottom bit, there's a little play sign there. I think yeah, there we go. Never mind. Okay, anyway, there's a blast wave that shows, and it's quite a nice illustration of the different components of a blast wave. Essentially, what's happened, you get this chemical potential energy that's rapidly converted from a solid liquid into this highly pressurized gas, and this energy is then released in a very, very short time span, milliseconds. And so that energy per unit time is huge, which is what makes it so effective and so powerful. And this blast wave consists of this high pressurized shock wave, which is this rim of air that kind of sits on this highly pressurized hot gas. And as it rapidly expands, that hot air, that hot gas expands, cools, and then slows. And then that pressure wave continues throughout. The two graphs on the right-hand side show the pressure wave in an open field setting and in an enclosed setting. And you can see in the one on the left-hand side, the initial one that says blast overpressure. This is what is known, waveform is known as a Freelander wave, and that represents this pressure change of a simple blast wave. You get this rapid overexpansion, overpressure, and you get rarefication, and the pressures then dip below ambient pressure, which then returns this ambient atmospheric pressure. In an open air explosion, that pressure time curve dissipates rapidly, as you can see, and the mortality is relatively low, around 10%. But even in open field conditions, you get reflection of the blast wave off the ground that then can interact with the primary wave and then change its characteristics, potentially increasing the injuries. In more closed environments, which is that graph to the right-hand side, such as in a building and an urban setting, you can imagine that blast wave interacting with the surrounding structures, creating these overwhelming, kind of overlapping complex waves that amplify, not only increasing potential injuries to the victim, but also increasing the amount of debris that might be available to cause secondary injuries. So there tends to be that the mortality in these confined settings tends to be a lot higher. Next slide, please. In addition, what else can determine injuries sustained from a blast? Well, there are three kind of predominant factors. One is the size, one is the device that they've used. So how big is the device? Clearly, the larger explosions are going to cause more potential for injury. The type of device, those suicide bombers are going to be inclined to go into places that are more highly populated and therefore cause more injury and more damage. The geography, where we've mentioned before, is a blast inside or outside, is an enclosed space, is underwater. And then the victim. Clearly, if the closer you are, the more proximal you are to a device, or the more likely you are to have injury. If you're wearing personal protective equipment, depending on your size, if you're a smaller child, the likelihoods that you're going to be thrown back from that blast wave and cause more injury as opposed to a larger adult. Next slide, please. And when we talk about the effects of blast, they're predominantly put into 5 different categories. Primary blast injury, which is purely related to that blast overpressure wave and how that blast wave interacts with the body, and the clinical effects of when that blast pressure wave, as it passes through the tissue layer, depositing energy, particularly the gas-liquid interface. So these injuries are caused predominantly by barotrauma, either kind of overpressure or underpressurization related to the atmospheric pressure. And you commonly get it in those airfield organs or air fluid interfaces. So places like the lungs, like the eye, like the middle ear. When we think of secondary blast injury, this is related to the energized fragments from the bomb itself or debris that's been kind of accelerated by the blast. And those injuries can be penetrating or blunt. And it seems to be, the secondary blast injury seems to be the most common cause of death in a blast event. And so these injuries are related to the debris that's been caused by the explosion. And commonly, secondary blast injuries are things like traumatic brain injury or injury to the neck, chest, and abdomen. When we think of tertiary blast injuries, this is when the victim has been forcibly displaced by the blast wind against other stationary objects, and so commonly being thrown against a wall. When we think of quaternary, these are things like the burns or smoke inhalation, or including the psychological trauma as well, or some form of exacerbation of their medical condition. And then quinary, this is the very rare circumstances where you may have clinical consequence of post-detonation environmental contaminants such as sarin or anthrax. Next slide, please. So in an acute blast situation, what happens to the patient? Well, initially you have this profound activation even of the autonomic nervous system. And in the child, you imagine that is a lot more pronounced. And so you have blast exposure to the thoracic cavity, and this can relate to this reflex triad of apnea, bradycardia, and hypertension, which is predominantly vaguely mediated. That overpressure wave hits the chest, and then you take a kind of sudden hyperinflation of the lungs. This can then stimulate variety of receptors in your lungs, and then this promotes this increased vasovagal response, which leads to apnea, and then rapidly followed by bradycardia and hypertension. Interestingly, the apnea can last up to 30 seconds, in which I think in some cases is why people will end up being brought to the emergency department dead, but have no external signs of injury. But presumably this is because they've had a significant apnea and not been able to receive appropriate pre-hospital care at that stage. Bradycardia can last up to sometimes 15 minutes post response, and the hypotension can last almost up to 90 minutes, sometimes 3 hours. And so there may be a role for use of vasopressors early. Next slide, please. But despite how complex the blast is as a mechanism, and despite the various categories, it doesn't really, those categories in terms of primary, secondary, tertiary, quaternary, doesn't really have a role in the management of the patient. What is important, and it's important to remember that the most preventable death, most preventable cause of death from an explosion is believed to be hemorrhage, and this is certainly the cause on the battlefield. And it's thought that, as I mentioned before, that many children in these settings will die prior to reaching hospital. So stopping the bleeds is essential, whether that be through compression, tourniquets, dressings, use of tranexamic acid or pelvic binders. Stopping the bleeds prior to the child getting to the hospital is essential. Next slide, please. And although we've mentioned that blast is a complicated mechanism, if we follow the systematic process, we've all been trained for multiple times, running through, stopping bleeding, opening the airway, optimizing the breathing, optimizing cardiovascular status, assessing for disability, and then exposing the child. We've run through this in a systematic way, using our best team-based approach, but also then maintaining a very high level of suspicion, because children are particularly vulnerable, not to only just have one system involved, but have multiple systems involved. Next slide, please. So Hannah's touched upon how children are more vulnerable in conflicts, but also they have a slightly different injury pattern, and there are certainly subpopulations that are more vulnerable. And as you said, children are not a uniform demographic. So we can have the 2-kilo child having very different injuries to the 100-kilo 16-year-old. And as Hannah mentioned, the subpopulation that seem to do worse in blast are those patients with head injuries and burns, and those under the age of 5. Next slide, please. So very quickly touching upon the specifics of blast injuries. When we see somebody that has primary blast lung injuries, this relates to the change in pressure differentials across the alveolar capillary membrane. And so you can get vessels displaced into the alveolar space, so-called spalling, and then it ruptures into the alveoli, and then you get compression of the air in those broken vessels, which we call implosion. And there seems to be these kind of 3 tiers of primary blast lung injury. You get the initial apnea, and if you manage to recover from that, or you get good pre-hospital care, you can potentially then have primary lung injury, which looks like this X-ray, so-called kind of bat wings that you might see, that can develop up to 48 hours after the injury. But then you also get this degree of inflammation, which is very similar to ARDS. But the management is the same as per our normal kind of ICU treatment of anybody that has significant lung injury. So it's optimizing ventilation as best you can with lung protective strategies, ensuring that you drain any hemo or pneumothoraces as able, restricting fluid intake if possible. Approximately about 80% of those that are exposed to acute blast injuries potentially can end up ventilated. Next slide, please. When we think of blast injury to the abdomen, it seems to be a lot more common in children compared to adults, and the mortality seems to be reasonably high. The spectrum of injuries is reasonably broad, and so you can have penetrating injuries to the bowel, obviously from kind of secondary debris that's been thrown, but injuries to solid organs seem to be relatively rare, and even if they do happen, a lot of time they can be conservatively managed. But what can happen is that you get these little petechial hemorrhages from the shear wave and the shear stresses that happen between the two tissue waves as that blast wave is transmitting through the tissues. And then you can get these small little petechial hemorrhages that are, slowly can coalesce and become more confluent over a larger area. And so what is important to remember in somebody that sustains an abdominal blast injury is that repeated clinical examination is important, not just that initial CT finding if you have access to CT, but repeated clinical examination to look for signs of ischemia, perforation, or peritonism. Next slide, please. Traumatic brain injury seems to be incredibly common, and certainly that's what we saw a lot of in Gaza, sadly. And there seems to be some a little bit of controversy about how this occurs. There seems to be obviously the direct cause of traumatic brain injury, so people being thrown against stationary objects and causing direct traumatic brain injury in that respect. But also there's a potential mechanism for indirect brain injury through just that shear acceleration forces, but also that pressure wave being transmitted through the venous circulation. There may be a component of vasospasm as well within blast injury or traumatic brain injury related to blast injury. But the unifying message is that even though the child may have other systems involved, having good pre-hospital care, ensuring that the child is having their airway open, receiving oxygen, stopping any bleeding that's evident, and then trying to optimize their neuroprotection is essential. Next slide, please. Burns certainly represents a massive cause of morbidity and mortality in children. And we know that children with inhalation injuries have a higher mortality than adults. And there's certainly an increased complexity when it's added with other limb injuries. In a lot of these conflict settings, the proportion of inpatients with burns or other limb injuries makes a significant workload, a massive workload for the surgical teams, with repeated trips to theatre, repeated grafting, and then unfortunately often limited access to rehab. And as others have spoken to, it can be significantly complicated by lack of access to nutrition. I can move on, thanks. And go on again. And the final slide, last slide. Great. So as a rapid stop tour of kind of clinical effects of pediatric blast injuries. They do generally have the same kind of injuries as adults, and they generally see the same kind of treatments to adults. But there are a few unique challenges and unique differences that we need to be mindful of. But if we can manage an injured adult, we can definitely manage an injured child. It's just to be aware of the slight differences in anatomy and physiology, but also some of the challenges that we've mentioned. But we should be approaching these patients in the same way every single time, following the same approach, same format within a team. And having worked in a few of these settings, the important thing to me is that we should be doing the basics well. So if there's a child that's bleeding, we should stop that bleed prior to get to the hospital. If the child is unconscious, we should make sure they're either in the recovery position and they're maintaining an open airway, or if they've got signs of traumatic brain injury, we should try and do everything we can to try and retain that neuroprotection. Thank you.
Thanks so much, Gavin, for a fascinating whistle-stop tour of blast injury and its management and peds trauma in general. Just a reminder, if anybody does want any more information about this particular topic, Gavin will post again the website for the Paediatric Blast Injury Partnership in the chat. You can go there and express interest in the manual, the courses, and whatever else you would like. We've got about 10 minutes left for a few questions that have come through. As you can see, if you would like to contact anybody directly, there are their contact details, and everybody's perfectly willing and happy to be contacted to try and answer your ongoing questions. Just to quickly try and squeeze in a couple of questions that came through. Thank you very much for those of you who have posted. We might not get to them all, but any we don't cover, we will get a written response for you. So I think the first question that came through was from Juliet Mbelli, who works for UNICEF in Chad. And I guess this is for our nutrition speakers, maybe Najwa, if you're around. It was about what mechanisms are in place to try and coordinate nutrition response across broad areas and across different countries, and whether anybody has anything they can explain to the audience about that.
If I may come in,
Please.
we have we have the global nutrition cluster, and it's I could share with everyone the webpage. This is a global nutrition cluster platform to support for global coordination. Yet each country has its own mechanism, and it could be a sector coordination that is led by the government, and if government capacity is not in place, partners could coordinate together, and UNICEF has a role to establish a cluster coordination. Over.
Fantastic. Okay, so the UN mechanisms there in place at the cluster, aiming to try and coordinate such responses, as well as within their own, as well as country's own responses. We had another question, perhaps again a sort of little bit nutrition and a bit clinical based, about iron supplementation. From Faraz. He highlights how it's important to remember that low hemoglobin levels do not always indicate iron deficiency, and understanding that, at what age should we consider iron supplementation for anemia or anemia prevention, and what sort of period would you recommend for children in conflict settings or difficult settings for iron supplementation with anemia? I guess this question was generated during the talk of Dr. Hans, if he's around, but otherwise perhaps Najwa or Gavin or any of the other clinicians as well.
Again, if nobody is here, the WHO guideline is iron supplementation is advised above the age of 6. Below the age of 6 months, it is advised to encourage breastfeeding and encourage mother to eat diverse food. In terms of if there is clinical symptoms of iron deficiency, then we could start the iron supplementation based on the pediatric assessment. However, for a prevention, we don't do iron supplementation. You could do after 6 months, you could do SQLNS, small quantity of lipid-based nutrients, or medium quantity lipid-based nutrients as a supplement, or we encourage complementary feeding in emergency, or the complementary feeding guidance where it shows the need of diversifying the food items. Over.
Thank you so much again. So for your response, and yeah, really interesting, and making sure that we don't sort of overtreat patients unnecessarily. Obviously, still very important. A question for Arij, if you're still online. Yes, about developing a child-friendly hospital environment. So, what are the key steps to creating a child-friendly and healing environment in a hospital? And are there certain elements that have been proven more effective than others?
Yes, hi. Yeah, so definitely when we talk about that, it's very important that we include age-appropriate and safe toys for children. For example, really basic, we're not talking about something very big, just sometimes soft stuffed animals, books for children for different age, making sure that the recovery areas have some cheerful colors. When we talk about informational materials, it's important that they are child-friendly. As we said, one thing is to make sure that there is a play area and some materials for children to play with, because this is not going only to help them, to distract them from the treatment, but also will allow them to express themselves and cope better with the challenges. Now, if, as we said, possible to provide medical toys or safe to use medical equipment, that would be really important. It's important in some places, especially that, as we said, like in conflict zones, that we provide them with basic needs that, like including food, water, and if possible, quiet area to practice. So really, when we're talking about creative, supportive, and comfortable environment, we just start with these basics of speaking calmly to the child, respecting them, trying to make sure that this environment is more comfortable, more child-friendly, and make sure that, as we said, the caregivers are not there. One thing just to say again, making sure that it is child-friendly is by, as we said, some of these basic considerations, not to promise the children things that are not possible to happen. Yeah, not to discuss procedures, for example, in front of the little children, or not making them witness or hear other children receiving painful procedures. I know in some contexts, like recently in Gaza, this was not possible to avoid. But in general, making sure really that children are not witnessing gruesome scenes, that's really important when we talk about child-friendly or protective environment in a hospital.
Thank you so much. And yes, highlighting how difficult that can be when conflict is all around for the children. I think that pretty much takes us to our time today. So I would just like to thank all the speakers for their efforts, as well as Humanitarian Learning Academy and Save the Children and everybody else who's helped put together. It's been a fantastic afternoon, really full of great information. Just to highlight, I think Dr. Hans mentioned a nutrition webinar in February. The link is in the chat. And again, if you would like to learn anything more about the Paediatric Blast Injury Partnership in particular, you can go to paediatrictraumacare.com. I think Rafi would like to just say a couple of quick words as well on behalf of our hosting team.
Yeah, I first of all just wanted to add my thanks. You're all extremely busy experts, and really grateful that you could give this time to share your expertise and experience. At HLA, we think it's a huge privilege to be able to have been working with the Paediatric Blast Injury Partnership on this kind of work, but we also recognise that treating children's injuries is just one part of the puzzle, and I think today has helped to open up the conversation and hopefully bring some different practitioners together. And what we want is just not for children just to survive war and their injuries, but also to thrive. And I think some of the speakers have given some examples of different areas where that's important. Just some housekeeping, we will be sharing all of the recordings and other resources and contacts with everyone who registered today. And if you do want any further events or events perhaps tailored to a specific need, thematic area or geographic area, then please do get in touch, and we'll do our best to accommodate you. And thanks again to all the speakers.
Thank you all for attending. Thank you again to the speakers, and we look forward to seeing you in future webinars. Take care.
Okay, thanks. Bye.
Thank you so much.